Welcome to Med Practice Made Perfect. I'm Tom Maher with Practice First Medical Management Solutions. Not everyone thinks of a medical practice as a business, but it is a business, and people want to be treated. People want to be treated the right way, and not just by the doctor or the healthcare provider, but by all the staff. So it's very important to. A lot of times, medical practices, of course, the folks are very empathetic to whatever the person's medical plight is, but we have to find the right personality type to be able to go and still get that money from the patient up front. It's vital to for the practices to flourish and survive and be available for people. The funds have to be there, and it's the whole idea. We have conversations with practitioners, years and years ago that didn't want to charge co-pays, and there's a real good reason why those co-payments are in there. I mean, from an insurance company standpoint, they don't want the services. They don't want the services overused. I think of easy examples of new parents that have a child, and every time there's a runny nose, they want to run the child to the doctor. Well, it's not necessarily a great use of resources or necessary for that matter. And if they didn't have to pay anything, they'd be probably maybe a lot more willing to go run to the doctor once a day. Rather than wait it out for a couple of days and just make a phone call. So medicine, of course, has changed, and the delivery of medicine has changed substantially over the last 25 years, the last 5 years for that matter. So quite a few things there. So the other part that's really important beyond your front desk people and kind of making a decision as far as how are we going to determine how much money we're going to charge up front. I think we can talk a little bit about the idea of how do I set my financial policy, and setting the financial policy is there's a lot of things to a financial policy, and one of the most important things about a financial policy is that it's like public information. It needs to be available. I can't tell you the number of times I've gone to a doctor's office and they want you to sign a pad, signing off on the HIPAA authorization, signing off on the financial policy, but you can't read anything. You can't see what it is. You don't really know what you're signing. Normally people would never sign off on that type of thing without reading it, but in a physician's office, that folks do it. And I think that's a real big mistake when you get into financial policy. And the reason is that, first of all, it's really not fair to have a financial policy that someone doesn't really know what they're signing on to. And, it's one of those things in today's society, it's, not a lot of folks love confrontation, but, I think the idea is that, you got to be upfront about these things. And if you're upfront about what the rules and regulations of getting service at my business, my practice, my medical practice, what that is all about is, that folks understand. So they're not surprised. They're not surprised when they get a bill. They're not surprised when they, leave the office and they get get words from from your front desk person that says, geez, you owe, $189, and, I've got these many different ways to pay. Well, that would have been really nice to know before the patient went back and got the service. So, look, people really want to be treated fairly, I think. And, look, it's not just about the medical care. It's about the idea that, you want them back. In like any customer, you want the customer to come back. Okay. So we want the patient to come back for service. We don't want them to be irritated or annoyed, especially after their first visit. which can be, they could be in a situation where, maybe they got some bad news and, we don't need to make it worse, out, trying to collect that money at the front desk. So, having a financial policy that is well thought out, that is posted, where people can read it on the walls, in the exam rooms, on your website. There's nothing to hide here. I mean, it's all important. It's all important stuff. And I think the patients that are going to make a decision, if you're fair, when you're setting your financial policy up, if you're fair, I would sincerely doubt that a patient that had any intent of paying their bill and paying what their responsibility is would really have a problem with your financial policy and not choose you because of your financial policy. Now, as I've told many providers over the years that, if you, you have to, you're forced to collect that patient responsibility for some of the things that we spoke about, earlier about the overuse of services and so forth. So those amounts are due, but if you don't enforce it, if you don't send folks to collection, if you don't, make a good faith effort to do that, I'm going to tell you, I mean, the word gets around, and when people find out that, you're not real tough about getting paid, they're going to bring their deadbeat friends along too. So, and you're going to be stuck with a practice full of people that, aren't paying their fair share of the bill. And, long term, that really hurts the delivery of your services. And, it's just a tough thing. So, getting back to the idea of, what is important inside of, these financial policies. I mean, there's a few things. So, I think, the first thing is that, the elements of this, as far as, what do we want this to contain? What do we, what message are we trying to deliver? I think the general idea is that, we're focusing here on, collecting the patient responsibility up front, rather than chasing this in the back end through patient statements. And, I'll tell you, if you're a specialist, it's much harder to get paid on the back end, especially if it's a one and done situation where you're not going to see the patient again. A little bit different in primary care because they typically have a relationship with you. They typically want to come back. They come to you anyhow because they like you. A little bit easier, but it costs money. It costs money to chase money. So, the second part of this is, making sure that you tailor your policy to, the differences in your practice versus another. I mean, a policy might be different if you're a specialist versus a primary care practice. So, also, as I mentioned earlier, we've got to make sure that the policy, very, very good idea to have your attorney review your policy. Once you have all your financial details and so forth in there, make sure that, you're meeting all of your, federal, state, and local laws. We want to make sure that we're in compliance there. So, I mentioned a little bit earlier also, post this policy, post in the office, post in the exam room, put it on your website. It's not a secret. People need to know what it is, and that's important. One of the most important parts of it after so you're communicating this information to the patient. That's great. But, when there's a dispute down the road, the idea is that, the person has to acknowledge it. So, how do we acknowledge the payment? How do we acknowledge receipt and of this policy? You have to have it has to be signed. So it has to be signed by the patient, saying that they've acknowledged that they've read and received and understand the financial policy, period. And lastly, you've got to store this. So most EHR systems, electronic health record platforms, have the ability to take a scanned sheet of paper and scan it into your into the software. If you've got a place where they can electronically sign it, but you also want them to, give it to them. You want to give this to them so that they can read it and take it home with them and ask questions or whatever. I mean, but you need the signed version of it so that you can back it up. If you go to collection at some point, the patient's account goes to collection at some point, you have to have something to back up what your financial policy said you were going to enforce, basically. So, there's a lot of things in there. As far as some of the essential components of the financial policy. There's many components. So, I think the most important thing is that, we state, payments expected at the time of service. Traditional plans, that means, collecting co-payments up front, capitated insurance situations as well. For traditional high-deductible type plans, we're looking at this idea of coming up with a standard new patient or established patient fee, or if you want to if it's not overly complicated as far as the number of codes you're billing and so forth, establishing that idea of collecting the actual amount, assuming your provider in the back is coding, and it's real easy to calculate that dollar amount up front. So you're going to have standard dollar amounts. I mean, if you have a simple level 2, level 3, level 4 for their insurance company, I mean, you can easily look up and see what that allowance is, what you're allowed to charge, what they're going to pay, or what they're going to allow, and what that patient has to pay, and collect that up front rather than waiting for that claim to process and you to bill it on the back end. So, again, the idea is let's keep the patient out of the exam room and wasting the provider's time with something that's going to end up as unpaid. So, another option, that you could enforce is if you don't want to go, too extreme as to collecting money up front for whatever the reason is. The other idea is, okay, look, if you don't pay the amount due at the time of service, you're going to agree to, a tacked on fee or $5 or $10 billing fee, basically a $5 or $10 billing fee to be invoiced. I mean, each patient statement that goes out the door, years ago, they were, basically the cost is about $5 a statement. That's important, and we'll talk about that a little bit, the billing part, in a little bit, as far as, small balance policy and so forth. So, typically inside the patient statement, or inside the financial policy, what we're going to do is, once that insurance is processed and settled, the payment's made at the time the service is applied, you're going to end up with, in the situation we talked about earlier, where we're going to charge a flat fee for new patient and established patients. There's going to, it's not going to come out to be an even dollar amount. I mean, you could have, maybe the insurance carrier allowed on the new patient $180 for the services you provided. You collected $125 up front, and so they allowed $180. They paid $125. I mean, we've got $55 balance due by the patient. So we're going to then have to bill that patient for $55. Okay, assuming that that's the situation. You could have a high deductible. It's the same. It really doesn't matter. Once you're in a high deductible situation, the same thing could happen. They could allow $180. They would pay nothing. The $125 is applied up front, and you're billing for $55. If you didn't collect that money up front, maybe you collected $20 up front. You're chasing a lot more money. You have a lot more money at risk on the back end. So, when we get into the billing the patient, the idea there is that, we're going to bill the patient after, all the insurance has been, filed, everything's adjudicated. We've taken the allowance off of our customary fee that we've established. We've been thoughtful about establishing a customary fee schedule. We didn't really talk about that too much, but, we want to establish a customary fee schedule that is, that's fair and reasonable to patients. And, if you don't want to be shorted from any of your insurance companies, those fees need to be higher than what that insurance carrier allows. So, again, when we get to the back end, all that's left is the financial responsibility of that patient. So, we're going to bill that patient. I would suggest you bill them every 21 or every 28 days on a cycle. 2 or 3 statements with increasingly stronger dunning messages. Telling them that this amount is now due for services rendered here and there. Of course, you're going to have a good you're going to have a good explanation of what the services were, and you're going to bill them 2-3 times, and then the last invoice is going to say we're going to send you the collection if we don't hear from you. If you decide to send 2 statements, maybe you want to use a pre-collect notice as your third quote unquote statement. You can do that as well. That works before you send it to collection. That sometimes gets people attention. Sometimes you put it on different colored paper. It alerts the patient that, it's time to pay this bill. It's past time to pay this bill. So one of the other things that you can add into your financial policy that, a lot of folks don't take advantage of, and again, you got to check your state and local laws as well on this, but, there are many places that will allow, there are many areas where you're allowed to add a collection fee onto the amount that gets referred to collection. So, okay, well, why is that important? Many collection agencies charge, in the neighborhood of, a third to, I've seen as high as 40%, depending on the size of the balances that are being referred. And, that comes right out of what you normally would have gotten had you gotten this money up front. Had you received the money up front, we wouldn't be talking about collection agent and then giving away a third of the money. So in the case where, you do have to, send this to collection, you add the 1/3 on, and you've told the patient up front that they're responsible for the collection costs. You send a $100 bill to collection, we make it say $135. So you net back down to $100, whatever that fee works out to be. You're perfectly fine to do that. The patients acknowledge that they will accept this fee, and we're as happy as we can be, despite the fact that we're getting paid a lot later than we normally would. Good to remember though that once it gets to collection, the likelihood of it getting paid. The typical yield I see out of collection is in the neighborhood of 20% at the best. Net. So much better to get this money up front. So one of the other components that we want to have inside of this plan is we want to make sure that we have a return check fee, service charge of $50. Very easy for your bank to charge you $50 for a return check. And with that stated, as far as a return check goes, we also want to make sure we have all forms of payment availability for folks, short of accepting cryptocurrency. I think we want to make sure that we take Apple Pay, we take Google Pay, etc. All credit cards, debit cards, and so forth. Talk a little bit about the idea of charging for forms. It's an important thing. Sometimes these requests are for large numbers of pages. It's records that we've got to print out of our EHR, or if we have a paper record scenario, or we've got to go grab records and copy them. So you want to handle that as well. No-show fees. We want to establish no-show fees. Depending on the type of practice you are. If you're a specialist, you might be in higher demand. You might have a higher no-show fee. If you're a practice that's seeing patients regularly, 3 no-shows in a year, no-show being defined as, you don't give us 24-hour notice before your appointment, you get charged, whatever, $50, let's say. 3 no-shows in a year, you're discharged from the practice. Again, they've signed off, they've agreed to this. If you have out-of-network carriers, patients that want to see you, but they're out-of-network, you can establish a self-pay fee schedule. Another really important thing that's really come on the scene recently with the whole No Surprise Act, bill that came on the scene federally January 1st, 22, is the idea of providing good faith estimates to your patients. A very we could do 2 episodes talking about this, but good practice to stay in compliance, to make sure you're doing this where necessary. Uh, Talk a little bit about small balance policies. Very good to establish the idea that, hey, look at, it costs $5 to send out a bill. Balances that are less than $5, we're not going to send them a patient statement. Balances that are overpayments of less than $5, we're not going to send a statement. So $5 either way, we're not going to collect and we're not going to refund. So again, double check and make sure that's good with your, state and local folks and your attorney. Most places it works out pretty good. Payment plans. We want to have payment plan parameters set up 2 to 6 months. That's how we're going to collect the money. We talked a little bit earlier about the establishment of, the high deductible plans, how we're going to go after those dollars. Again, we could do a whole episode on how to go through various ways to calculate that. Thanks for listening to Med Practice Made Perfect.